Hello everyone and welcome to this Vulval Pain Society social media live and the first of our psychosexual medicine specials. Thank you for joining us live and thank you if you're joining us for a replay as well. I'm Sharon Goulbert, Vulval Pain Society trustee, therapist and pain science educator. As always, please say hi in the comments if you're watching, just so that we know that the tech is working. And Kay is in the background, who's already said hi. Marion, hi, thank you for joining us. And I too am going to be slipping off into the background and I'm going to be in the comments boxes today. Rather than me, we have my fellow trustee, Dr. Winston de Mello, consultant in pain medicine, and he'll be chatting with Dr. Catherine White, specialist in psychosexual medicine and specialty doctor in integrated sexual health. Dr. White is a member of the Institute of Psychosexual Medicine, and today's topic is the Institute of Psychosexual Medicine approach to life. Hello, Dr. Cath White, and hi, Winston.
Hi.
Good evening.
Hi. Hello.
Good evening to everybody.
And of course, you know, it might be good morning and good afternoon by the time people watch the replay as well. So, and wherever you might be in the world, who knows? So, Winston, Cath, you both know each other already. So, tell us a little bit about how you met.
Winston?
I think we first met at a postgraduate meeting in 2018 where Cath was one of the attendees. I'm not really sure what happened after that, but a few weeks later, I found myself enrolled on the IPM diploma course. So she's got a lot to answer for. Dr. White, welcome to this podcast, and we're looking forward to this chat tonight.
Thank you very much. Please call me Cath.
Okay.
And the IPM, for anyone who's wondering, the IPM is the Institute of Psychosexual Medicine, and I guess throughout the talk you'll be abbreviating it to the IPM. I'm going to continue watching the background now. I'll be back a bit later on to pick up perhaps on some comments and any questions and then wrap up. So over to you, Winston and Cath.
Okay, thank you. Cath, could we just start by telling our audience a little about yourself and how you got into this specialty area?
Well, as you said, I'm Cath White. I currently work at the Northern Sexual Health Clinic in Manchester as a specialty doctor in integrated sexual health. But I have a specialist role there in psychosexual medicine where I take referrals both from within the service and from GPs and consultants in many different specialties. I actually been in sexual health probably for nigh on 30 years and have been a general practitioner alongside that until 5 years ago. But sexual health has always been something I haven't quite been able to give up. And then 10 years ago, just because really I was starting to notice just how many patients either came to the sexual health clinic or the general practice with sexual difficulties. And I thought, really, I don't know how to help them best. And so sought out some training and came across the IPM. So for me, that's where it all started.
Right. Can you just tell us a little bit about the Institute of Psychosexual Medicine, a little bit of its historical background?
Yeah, it's a registered charity, and primarily it's about education and training for people. It started off by, well, there are two people involved. One is Michael Balint, who GPs may be very familiar with from Balint groups, and the other Tom Main, both of whom came to England from abroad. So Michael Balint came from Hungary, fled over here in the Second World War, and he was a doctor and psychoanalyst. He then came across Tom Main, who was a South African doctor who'd come to England at the end of the war. and joined the seminar groups that Michael Bailent was running. And these were really about supportive learning in seminar format for GPs primarily. That then extended to family planning doctors. And I think particularly Tom Main realised that patients were presenting to the GPs in the group with, and the family planning doctors with sexual problems. And so this specialty was developed, I suppose, is perhaps a basic way of saying it, but this experiential learning and bringing problems to the group and realizing perhaps that there were many conditions that just didn't respond to the usual medical model, and realizing that it was more about how the mind was affecting the body.
And we talk about the IPM method as another approach of dealing with these group of patients. How would you describe it to people, what this IPM method or approach is? What is it all about?
Essentially, we offer a brief type of therapy. So it's not long-term psychoanalytical therapy. It's usually a brief intervention, but it's based on psychoanalytical principles, as well as drawing on medical knowledge and skills. And in it, we see the patient as the expert. We don't really profess to have all the answers, but instead we recognize that their sexual difficulty may be a symptom of something which is held in the unconscious part of the mind. It may be something of which the patient's unaware. So through the use of appropriate questions and really active listening, and then reflection back to the patient and summarizing what we feel, we can start to help them unravel and understand how the mind and body fit together.
Right. This concept of feelings in the room is quite interesting, because before I even started on the course, I always used to think about the feelings of the patient, but I had never ever before considered the feelings of the therapist and the interaction between the two. Can you explain the sort of the concept of feelings, and also how do you get out of the patient who's got the expertise and often possible solutions to the problem? How does it work?
I think that what we have to be very aware of is that we all have developed ways of managing our emotions and our responses to situations, and we carry those traits, I suppose, or ways of coping around with us wherever we go. So as therapists, doctors, nurses, physios, whoever we are, we bring ourselves into the room with the patient. So noticing the things that we might be feeling, even as simple as it's a really rushed clinic and we came in and we felt irritated by something that had gone on before, and that is going to impact on how we interact with our patient in the room. And I think it's about realizing that the patient too is going to bring their previous experience and their sort of learned methods of coping with, say, anxiety or any other emotion that they may have, and bring that into the room with them. So it's about, I suppose, sensing what we can feel rather than just listening to the words that are said. So the patient may be saying something and I might find myself feeling extremely sad, but not because of the words that are being used by the patient, but perhaps they're being transferred across to me from that patient's unconscious. So by reflecting back and perhaps commenting on it and suggesting that, well, actually, I feel overwhelmingly sad at what you're saying. And sometimes that can trigger something in the patient that helps them unravel what's really going on, rather than the sort of learned responses. So it's perhaps about being much more instinctive, I would say, than formatted. Does that make sense?
Yes, it does. The other thing that it emphasizes a lot is observing the patient's demeanor, the dress, the body language. Why is that important?
Well, I think we all develop defenses in order to manage our anxiety. It's a bit like a sort of safeguard mechanism. And I mean, even as simple as, you may find yourself, if you're feeling quite guarded about somebody that you're with, you may find yourself crossing your hands across your lap, you know, protecting your body. And that's a very instinctive thing to do. And I suppose it's important for us to recognize right from the initial engagement, maybe calling your patient from the waiting room, how comfortable they are, how relaxed they are, the way that they, I suppose, the way that they come into the room and how they sit, whether there's good eye contact, whether they're comfortable discussing what the topic is, or whether there are all kinds of other techniques to distract you away from the actual problem. But I think if you even just think about your friends, your family, which is why I call it an approach to life as opposed to just a way of working, then starting to notice how behavior really tells us often what's not being said. So it's as much about what's not being said as what is being said.
Mm-hmm. The other feature of the IPM approach is the judicious use of silence, and I found that very difficult. For the benefit of our listeners, can you explain the basis for that?
Well, I think that's certainly the practitioner, whoever they are. We can often be quite uncomfortable with silence. We're used to being in a position that we're answering questions and we're there with all the sort of set format for a particular condition that we want to churn out, and we're the expert. And this is about recognizing that sometimes only by leaving a silence between you and the patient will that silence be inevitably filled by what really is going on in the patient's mind, because it will spill out given the opportunity to do so. But we're very good at being defended by frantically, you know, I don't know, doing prescriptions or giving diagrams or lists of possible answers to a question. And in actual fact, it's about, well, what does a patient really think is going on? What are their fantasies and thoughts about the thing that's causing them distress and difficulty? Because I think that's the thing we have to remember. Somebody who's come to see you, or who's inadvertently in a situation with you, maybe in general practice or at the physio, who just gives away enough in their body language that there might be something more, but it's difficult to say. And
right.
So silence is a space that they can put that in,
where they feel safe.
Yeah. And I think it's the job of the therapist to sort of contain that discomfort and be able to sit with the silence. We become aware of our own discomfort in those situations, and containing the space, I suppose, gives the patient an opportunity to then bring their feelings and thoughts into there.
I've trained in the 1970s at Guy's Hospital in London, and we were always told you take a history, you examine the patient, you make a diagnosis, you get investigations, and then you treat the patient. But IPM have got a rather different approach called the therapeutic benefits of an examination. Could you sort of explain that to our listeners?
Well, obviously, first and foremost, with an examination, you are there to exclude sort of organic disease. But then there is a lot to be gained from how receptive somebody is to being examined. You can sense whether there's fear, whether there is almost a disconnect with the area of their body that's causing them so much distress. So it's really important, I think, to notice, can the patient engage with you? Are they, what I usually say, in the room? I find myself sometimes when a patient will often say, can you just get it over with, just have a look, get it over with. And I think, well, actually, no, I can't do that, because in order to learn anything, I need you to come back in the room with me. I need you to try and engage with me. And that's a moment of great vulnerability. And sometimes being in that position then enables, I suppose, even deeper feelings to be mentioned. So it's about allowing someone space to explore their ideas and their concerns about what is going on. Because all too often people might present and they're just told, oh, everything looks normal. And then that's supposed to be okay. And in actual fact, it's, well, what do you feel is going on? What's your idea of what your vulva is like, or what the inside of your vagina is, or what is happening in this process? So it's
so
very much. Sorry.
So quite a lot of patients will have seen other specialists before they see you, and quite often they're told there's nothing wrong with you. Do you find that a problem when they've had it?
I think this is when we can come back to kind of the use of feelings in the room, because you can sense that somebody is thinking, oh God, here we go again. There's often quite a despondency and a hopelessness around thinking, patient may be thinking, look, I know something very physical is happening to me. I know I can feel a very specific pain. You just can't see it. So it's perhaps about trying to make them aware that you are interested in that, and you understand that there is this connection, like there is with anything. I mean, going back as far as you can think, we know that there's a mind-body connection. And I think it's almost become a little bit of a sort of dirty word, things like psychosomatic. People think, and probably because lots of clinicians have maybe said this in the past, they think, oh, you're telling me it's all in my head, you're telling me it's not real. And no, that's not what we're saying at all. We're saying that your mind is a very powerful force. We also know that from research more recently, we know how our bodies are sort of just so much more complex, I think, than we ever have imagined. So there will be lots of sort of neuroimmunology and all kinds of things which no doubt in years to come will unravel some of this for us. But we do know that in order to make ourselves more comfortable, we find a way to defend it, that distress.
Right. And another feature of the IPM method is the sort of recognizing the defense mechanisms, not just of the patient, but also of the therapist. Could you give some examples of that?
Well, I think a bit like I mentioned when you bring the defenses, say, of needing to be the expert, and you resort to intellectualizing things, and because that feeling that you've got in the room is a bit too uncomfortable to manage, or we might just pretend that we're not noticing something about the patient. We might I would say make collude with if the patient's rationalizing something, because again, it's more comfortable for us. So if the patient says, oh, you know, I can't possibly do that, I'm far too busy, and you know, my mother's in the room next door, and we'll get round to it once we've moved house. And instead of actually looking at why, say, some kind of sexual interaction might be being avoided. So we can have all the same sorts of defenses as the patient can. We're all people at the end of the day.
Mm-hmm. And quite often we mimic each other in our defense mechanisms, like anger, for example.
Yeah, I mean, you know, you might really pick up from you might start feeling very, very irritated with somebody sitting in front of you. And if you didn't go into that room feeling like that, you've got to think to yourself, where's this coming from? What's happening that I might be feeling suddenly irritated or angry? And actually, that's probably coming from the patient, and that's how they may feel towards someone else or something else or the situation. So you're receiving their sort of unconscious thoughts by being in that interaction with them. And then hopefully by recognizing that and maybe reflecting it back and talking to the patient, you can both start to unravel where these feelings actually are coming from.
Well, one of the things that that we have discussed during our seminar groups is the sort of the brevity of these interventions that the IPM offer compared to, say, having CBT or counseling or some of the other psychological approaches. Can you illustrate that? What you mean by the brevity of these interventions?
I mean, I suppose it's really about whatever consultation you're in, and certainly for the first, well, many years and still now, a lot of my psychosexual work is done within the context of a normal consultation. Say that might be a 10 or 15 minute consultation in sexual health, where I had no clue that there might be a psychosexual element. And if you notice that there's an arousal of emotion that maybe doesn't quite fit or you didn't expect, and because the emotions are sort of breaching the defenses, if you like, and spilling out into the room, just being able to acknowledge their presence can sometimes be an extremely powerful thing. A little bit like using the same technique with an examination. Examination might have just been a straightforward smear, let's say, or use of a speculum if somebody is presented with discharge and you're trying to do a usual sexual health consultation. And then I suppose the obvious thing is that somebody who has had vaginismus or is still suffering from that may find that utterly terrifying, but have so many concerns about what's going on, they've brought themselves to that room anyway. So acknowledging that rather than just ploughing ahead, and acknowledging those feelings that you can sense can actually be quite therapeutic. It sounds so very simple, but actually can be really empowering, I think, for people. Because then maybe you'll get to understand what their real anxieties are. Yeah.
One of the interesting things about the development of the IPM as a professional body is that it's opened its doors to allied health professionals. Could you just sort of give our listeners a little bit of a background of, for example, the makeup of these makeup of the students on the diploma courses, the backgrounds, just so that they can understand that it's not just for doctors?
Oh yeah, I mean, to me, this is one of the wonderful things that has happened to the Institute latterly, and that is, having started off as a purely medical establishment set up by doctors for doctors, I think it's we became aware that many people in different professions who interact with patients who have sexual problems were also in the same situation that we were in. They were hearing lots of stories of sexual dysfunction, sexual difficulty, and again, not really having an idea of where to go with that. And so we open our training to anyone who works in an environment where they may be seeing patients with sexual problems. But the important part of the IPM is that it's anyone who is also doing genital examination, because that genital examination is used as a therapeutic tool. So that could be a pelvic floor physio, it could be a nurse working in sexual health or maybe cancer care, in gynecology, it could be somebody working in urology. We have a very mixed group at the moment, because I didn't mention that. That's obviously, I think, from what Winston said about coming to my group to learn, and I'm an IPM trainer. So in our group, we have a GP who is trained actually in COSRT, sexual dysfunction therapy as well, and is now doing the IPM to complement that. We've got specialist nurses who work in sexual health. We've got a therapeutic radiographer who, he works with patients with prostate cancer, and again found himself in a situation where people were telling him about their sexual difficulties, and they're there in a very intimate setting. So this style of just having that 10 minutes with the patient and having an idea of how to maybe interact in a less formal way is helpful. So yeah, pelvic floor physios, nurses, radiographers, doctors.
Yeah, true Catholic in its selection. Could you tell us about the course, starting off with the introductory course, then leading up to diploma, and finally the membership? Just give us a brief overview.
So the what we call the introductory term is a relatively new addition, and we have a training committee on council who have done wonders in organising the seminar leaders to give introductory terms. And these have been very successful, both face-to-face but also online. And they are international as well as in the UK. I think that's one of the benefits that we've all found from working online, is you can extend your reach far and wide. But the criteria are very similar to what I've described already. Somebody working in any situation where they may see patients presenting with difficulties, and who are also going to do a genital examination. And the learning is all through bringing cases of patients that you see. So it's an extremely confidential environment. It is a case of, it's a bit like the Green Mile, what stays in the room, what comes in the room stays in the room. And we are able to, well, I will observe the group interacting, commenting on their interaction with the patient. So that would, there's a bit more theory in the introductory term. So we perhaps explain the principles more than just diving straight into a purely experiential situation, but there will always be case discussion.
Right.
So that's a 12-hour course. And I think we've had fantastic feedback from people who've done that and who felt, well, I don't really want to go on and do the 2-year diploma training. It's a minimum of 2 years. But that introductory term perhaps is just enough to shift their way of thinking, which can be empowering both for them and ultimately, hopefully, for the patient. So you can do your diploma exam, which again is case-based, where you will select cases from which your examiners will choose to discuss with you and for you to present to them, not in a medical style, but in a very IPM style.
IPM style, yes.
And then if you want to continue on, some people who feel that they've got quite a knack for this way of working, then maybe want to go on and do their membership exam, which will be a minimum of another couple of years of seminar training. And once they have passed that, then they're in a position where they could take referrals.
Right, as independent practitioners.
Yeah. So that's something very recently we have just opened up to our AHPs, which is quite a sort of a landmark moment for us. Mm-hmm. So prior to this, they were able to go up to diploma level, but not able to go further than that. So it's now equitable across those who come and get involved and learn with the IPM.
Excellent. If a listener wanted to know a little bit about training at IPM, where would be the best place for them to go? And secondly, would you recommend any a book that's worth reading just to get a idea of what the IPM method's all about?
Yes, absolutely. We have a website. I hope Sharon's going to pop that in the links. I have to say, it is in the process of being updated, so it will look shiny and new come the summer. But still, you can find both training packages on there, and some of our training committee will go out and do training for a group, maybe a department where they, particularly something like cancer care, say, for example, so that may be done as a group, or they may join an individual introductory term or seminar group. In fact, we've just made it, because we found the introductory term so successful, we've now said that actually that should be part of the diploma training, that at some point in that 2 years, you really should attend an introductory term.
Mm-hmm. And what about the reference book?
So there is a book which is called The Introduction to Psychosexual Medicine, and that's the 3rd edition. It was actually, I think it's probably maybe 2 years, a year or two old now since the updated edition. And that gives a really good sense, I think, of the type of work that we do. There's it contains a little theory. It also contains much more detail about the psychoanalytic principles and how we utilize them in the room. But I certainly think it's a very good overview of our ethos.
If a patient wanted to refer themselves to an IPM qualified therapist, how would they go about it? Do you need a referral from the GP or a consultant, or can they self?
So I think, I mean, there's a section on the website which is Find a Therapist, mm-hmm. And that is updated reasonably regularly. And on that, it will state, does this therapist work in the NHS only, and how to access them? Or do they have a private practice in addition, or just solely? So that's usually your first port of call. Now, I think for, say, for example, the pelvic floor physios, some of them work in private practice. None of them will have been training long enough to have done their membership and take referrals directly. But what they may advertise, and what it's worth you looking for, if you're looking for a pelvic floor physio or pelvic health physio, is, have they advertised an interest in psychosexual medicine? Right. Have they perhaps said that they're in training? Because I'm sure that's something that they may have on their website. I know our physios who have their Facebook pages for their pelvic health physio and Pilates will mention on there that they have an interest in psychosexual medicine. So, I mean, for our service, anyone who attends our sexual health clinics across the Northern service in Manchester, which is citywide, we have several clinics, they can be referred by a clinician that's seen them within the service, for example. But we don't tend to take self-referrals. Occasionally people do, and that will be in the Find a Therapist section on the website.
Certainly, the talking to colleagues in our seminar group, particularly the physiotherapists, I mean, the reason why they're getting so enthused about the IPM method is that it just gives them another tool to use for their patients. It's just like expanding the amount of services they can offer a patient, and most of them find it really useful. And you can see the changes in their use of the IPM method as they get more confident in being able to use it more often. So I guess it's like everything else. It's a skill you have to learn and then develop and mature as time goes on. Would you say that's...
Yeah, I mean, I think I personally find it quite difficult to describe the method. And I think that's perhaps why we ended up with the experiential learning, because it's really not until you're practicing the method or the sort of using those concepts with patients, and then using the groups to really reflect back on your behavior and the patient's behavior, and maybe what you might have done differently, or perhaps something about the patient that's made you behave differently from your norm. And I think that certainly the physios in our group have said that perhaps when they see patients who may be sent to them with vaginismus or vulvodynia or trauma from childbirth, and they, instead of just receiving perhaps pelvic floor exercises, suddenly the patient's got the benefit of somebody who perhaps can really start to understand their mind-body connection and how that's impacting on their life. And occasionally we've had members of our group say, well, gosh, I stopped doing my physio. I took my physio hat off for a moment and actually had a really successful psychosexual consultation instead. So it's not an either or, it's complementary. And I think that's where the brief intervention comes in really as well. These are skills that can be used within the context of whatever else you're doing.
Right. So you have these seminar groups dotted all over the UK, and I believe there's a group just started in Dublin this year.
Yeah. Northern Ireland, Southern Ireland, Scotland, Wales.
So the groups are led by a seminar leader, and you're one of them for our group in the Northwest. As a seminar leader, what gives you the buzz?
I think seeing the transition that happens when clinicians come along, maybe with a little bit of an interest, but a little bit skeptical because it's so very different from everything else they've done before. And I recognize in them the same thing that happened to me. It was like a light bulb moment. I suddenly realized that just actively really listening to the patient and using this sort of free floating attention to think about what's going on in the room between us. What are these feelings and emotions that are being aroused in both of us? It's so different from our usual medical model in which we were trained. And I think that you just get that buzz from seeing those clinicians just recognize that progress and how much more they can do for the patient. You know, so I get the buzz off their buzz.
Yeah,
you know?
and it shows. The other thing which I didn't realize until months into the diploma course is how much you have to do as a seminar leader, because you then have to go back to the IPM and do workshops and other sort of ventures that keep you updated.
So we will have our leaders workshops.
Mm-hmm.
So all the leaders who are from around the UK, and obviously this is slightly easier now that we're on Zoom for the time being. We will gather together and present our group, and then we have a group analyst. So
what is it that you take from our seminar group into that workshop?
So that may be that actually we might focus on a case somebody has brought to the group, and actually how the group interacted around that case, and perhaps whether we interjected or not. And so you can see the development of the members of the group by doing that, and what they're picking up in the principles that are being used, and also how they're able to be not overly nice to each other. I mean, I think we all have a tendency to do that. We sometimes do that in our own workshops, and we all shy away from being a bit critical, but after all, that's the way we learn, isn't it?
Mm-hmm.
So yeah, and obviously we have training days when we have invited speakers from a whole range of different places who come along and share their experience, their expertise with us.
You've had two very good study days on psychosexual topics recently. Would you just tell us about those 2 days, which I found fascinating?
Well, here's the thing, Winston, since you were there, maybe perhaps it'd be interesting to see what you took from a bit of that.
Well, it was mainly to be aware of the LGBTQ sort of subpopulation really, and their needs. And I found the study days just mind-blowing with information from experts. You know, you're getting it from the horse's mouth. But it also those 2 days also made me realize perhaps how undertreated these specialist groups of patients were dealt with in the past. I'm talking about myself now, and I think it's given me more confidence. I at least am more aware of to be more broad-minded and not to assume.
Yeah, I mean, I think the other thing is, I mean, we like to have a really broad range of speakers, and we're certainly not the IPM is the only way. I mean, some people really don't like working in the way that we work. Some patients don't, they just don't enjoy that kind of interaction, or they maybe prefer to be slightly more problem oriented, sort of a program set for them, and they may be far more suited to being seen by a different therapist. And so we invite all kinds of different people to come and speak. I think that at one of the days that you're referring to, because we have an annual clinical meeting and a scientific meeting as well in the year. And I think people really enjoyed Karen Gurney, who that's probably a nice thing to put in the links, is her Mind the Gap book, which is about mainly female desire. Yeah. And being somebody who doesn't do genital examination, she's not IPM trained, but she is trained. She's a sexologist who has got a huge wealth of training, as more from a psychology basis. So I've got huge respect for people in other parts of our discipline, mm-hmm. because at the end of the day, we're all interested in trying to help people with their sexual difficulties.
True, and it shows in the choices of topics to be covered in the programs run by IPM, which has been very good. Which brings me to my final observation. I believe on behalf of our group, I'm talking about Guy, Jackie, Angela, Maria, Nikki, Dee, and Felicity, just to congratulate you on your appointment as Program Secretary of IPM.
Thank you very much.
Just been elected recently, so we wish you every success and look forward to further meetings done by IPM, which I highly recommend to anyone listening.
Well, thank you, and that was very unexpected, but hopefully I can live up to Nancy Conroy, who's just handed the baton over, who's done some really fantastic days, and these are open across the board to other people who aren't IPM members, so they're certainly worth looking out for on our website. We're going to continue doing probably at least one meeting a year virtually, so that might be slightly more accessible for people. But watch this space, and perhaps people can email the Vulval Pain Society if they have if they think of somebody who they think would be fantastic to come and speak at one of our events.
Will do. Well, Kath, that's been a very enjoyable session. Thank you for taking the trouble to come and talk to us today, because we've enjoyed listening to you about the IPM method, and I couldn't think of anybody better to sell the therapy and also sell the educational possibilities for anyone listening. As you said, anyone who deals and examines genitalia, essentially being the basis for that entree. So thank you very much. I'm going to hand you back over to Sharon now. So if there are any other questions, I'd be grateful if you could just hang on for a bit longer.
Okay, thank you very much, Winston. It was lovely to talk to you.
That was wonderful. Thank you so much, Kath, and Winston. What a lovely conversation. I love that idea of, what are the feelings being aroused in us? Not just what are the feelings being aroused in the patient, but in us as therapists, in us as a clinician. So important, isn't it? Because it is a communication. It's a two-way thing.
Yeah. And I think that's why we like to emphasize that it's not a case of we're the expert and there's the patient coming for advice. It's I really like to think of it as the patient is the expert, and it's really, can we facilitate their understanding of what might be affecting their condition, really.
Mm-hmm. I think that's really important. The patient is the expert. They are the expert in the room, and they probably know far more, even if it's held at an unconscious level, than we ever would.
Yes.
So that's so important. We've got some lovely comments that have come in. I think it's been so informative that there haven't been many questions. There was one question early on about how methods have been affected during these times where we might not see people face to face. How do we read body language if there's a telephone appointment? And I just put in, voice tone, pacing of the voice, things like that. But what sort of, and this is someone who's got an appointment coming up and wondering how that might be read.
Well, I actually have been so pleasantly surprised at how effective telephone consultations have been. I think, again, you use those skills of really listening very carefully. You're listening, as you said, to tone and pace, hesitation. You can still use those silences, even on the phone. Sometimes people have found it even easier, perhaps, to disclose what their real fears and anxieties are, because they're not having to manage you being in front of them. So actually, a telephone consultation for some people is a really good sort of warm-up. I mean, for me, I've done lots of telephone consultations, video consultations, which again can be really positive because the patient is in their own environment and perhaps a little bit more comfortable than they may be in the clinic. And then latterly, I've been inviting people to come in for their examination because, as I say, that's an important part of our work. So I don't think it's necessarily a negative. I don't think you get shortchanged. I think it's certainly, because initially when the lockdown happened, I had people saying, I don't want to be on the phone. I want to wait till it's face to face. And then actually after a few months, when it became evident that we weren't going to quite go back to normal as quickly as we might have thought, I contacted them and said, do you want to reconsider? Would you like to just try a phone consultation and see how you get on? And actually, I haven't had a single person who said, oh, I don't want to do this again. That was awful. They've all said, oh, actually, that was quite good, you know. So,
Yeah.
So it can be a positive.
Yeah, absolutely. Yeah, agreed. Lots of thank yous coming in. And as mentioned, if there are questions that you people have felt they haven't been able to ask, feel free to email us. Our email address has been posted up, info@vulvalpainsociety.org.uk. Any final thoughts, Kath, as we wrap up today?
Oh, gosh. Which one shall I select? Just that it's been really interesting coming in and trying to share what more and more people are getting involved in, and really, I suppose, to stress that there is a lot of work being done to try and improve training, particularly for doctors, where there's been so much emphasis on the medical model. Certainly, Leila Frodsham is a consultant gynecologist, obstetrician down at Guy's, who's done a lot of work with training, vaginismus, tocophobia. And I think she's really quite passionate about extending this kind of training to all obs and gynae trainees, which is now part of that module. And myself with the sexual health trainees, I'm kind of waving a flag to make sure all of them are exposed at least to some form of learning in this way.
Yeah. It's good to hear. I know people have commented and said this is really good to hear that we are thinking about this relationship we have in the room, and thinking about, this isn't just a patient, this is a person, and these are two people.
Absolutely.
In the room.
Yeah. And you never know what will happen with that interaction. You see? So that's part of the delight of it. It is what develops and what becomes evident as a result of that conversation.
Because, of course, no two people are alike.
No.
Go in any direction. Yeah, absolutely. Listen, thank you so much, Dr. Kath White, for coming on today and just opening up that conversation. This was the first of our psychosexual specials. And thank you to our very own Dr. Winston de Mello for the conversation as well. Next time, 7 p.m. on the 5th of May, we have the second of our psychosexual medicine live streams with Dr. Angela Wright, GP, clinical sexologist and menopause specialist. She'll be talking about, I think this is going to be fascinating, how the vagina and vulva are affected by menopause. And she's going to come at it from a sexology angle. So physical changes, potential problems, drugs which may or may not be helpful, hormone, non-hormonal treatments. So I think that's going to be, info packed as well. Kath, you know Angela, don't you?
I do know Angela. Yes, Angela is actually in my seminar training group, but she's got a huge amount of experience and knowledge. She's done COSRIT training. She's done the European sexual medicine training, and it will be fascinating. She's very, very knowledgeable, general practitioner actually, and menopause specialist. Yeah. I think you'll enjoy that. It's very well worth tuning in for.
Yeah, absolutely.
Look forward to it.
Yeah, I think it's going to be a goodie. Reminder to everyone watching, whether you're watching live or on the replay, all our live streams and a selection of webinars are available to watch again or discover or rediscover on our YouTube channel. You can email us anytime you wish. Bear with us. We are a small team of volunteers. We'll do our best to get back to you as soon as possible. Connect with us on social media. We are on Twitter, Facebook, and follow us to keep up to date on upcoming live streams, events, and other resources. Do share posts or tweets that can be useful for people. And hey, up to 50% of the population may experience menopause, and the other 50% is likely to know someone who's going to go through the change, in inverted commas. So next time's live stream on how the vagina and vulva are affected by menopause may be a really useful one to share. I think that's going to be so informative, so useful. We hope you can join us then, 7 p.m, 5th of May, with Dr. Angela Wright. That is all from the Vulval Pain Society now. Thank you again, Dr. Catherine White.
It's a pleasure. Thank you very much.
Thank you, our very own Dr. Winston de Mello. Thank you all for taking the time, for being with us live or on the replay. Bye for now, and see you next time. Cheerio.
Bye-bye.